of acute ischemic stroke. I'm from China. During an acute ischemic stroke, time is bleeding. Every minute may lost many neurons, synapses. When the occlusion of the cerebral artery, the CBF will be digress, so it may be have core infarction. The core infarction the cell will die in 1 minute, and it also have some ischemic penumbra. This will be rescuable tissues. The basic principle of acute ischemic stroke therapy, rapid and complete recognition of the atrial occlusive lesion. How we can recognition of the atrial occlusive lesion? The one way is IV tablets. This needs the hour within 4.5. And another way is the mechanical lumpectomy. Need the patient 0 to 24 hours and have large vessel occlusion. We should notice that a patient eligible for IV tablets should receive IV tablets even if mechanical lumpectomy is being considered. Also, in patients under consideration for mechanical lumpectomy, the IV tablets would not delay the mechanical lumpectomy. How we can identification of LVO? The NIST score is the best of the LVO prediction instruments. The clinical symptoms can help with identification with consciousness disorders and gaze palsy. And in patients with suspected LVO, we should take non-invasive vessel imaging like CTA or MRI help us to identification of the LVO. Some preoperative head and neck image should be taken. The one is the non-contrast CT is effective to exclude ICH. So what patients would with suspected acute stroke should receive this examination. And when patients who awake with stroke or have unclear time of onset, more than 4.5 hours, we need to take MRI to identify diffusion positive. And the CTA with CDP or MRA with DWI MRI with or without MRP viewing is useful for selecting patients for mechanical lumpectomy between 6 and 24 hours after last known well. There is also other diagnostic tests. One, only the assessment of blood glucose must be measured in all patients. And basically, electrocardiograph assessments. Three, basically, troponin assessments. And the chest radiograph is useful less in the hyperacute stroke. And some general supportive care and emergency treatment should make. The one is airway, breathing, and oxygenation. Airway support are recommended for treatment of patients who have dysfunction that cause compromise of the airway. And we should sample oxygen should be applied to maintain oxygen saturation more than 94%. Also, the blood pressure we should maintain. Hypotension and hypovolemia should be corrected to maintain systemic perfusion levels necessary to support organ function. For the IV tablets and mechanical thrombectomy maintain the blood pressure less than 185 and 110. Also, the temperature don't higher than 38 Celsius. When it's higher than this should be identified and treated. And the blood glucose also should be tested. Hyperglycemia and hypoglycemia after AIS are associated with worse outcome than normal glycemia. So we need to test the blood glucose, which is the mechanical thrombectomy criteria for 0 to 6 hours from 1/3 should meet all the following criteria of about 6. When the aspects more than 6, it is good. So only based on CT and CTA or MRI, and MRI is recommended. No other additional images needed. Sometimes the benefits are uncertain, but when the treatment can be initiated within 6 hours of symptom 1/3, it is reasonable to maybe reasonable for some people. And for 6 to 24 hours from 1/3, I will in the anterior circulation need obtain CTP or DWMI, meets the eligibility criteria from one of the RCTs in done and diffuse 3. The done study is the theoretical about the mismatch between the clinical deficit and the infarct volume. The diffuse 3 is about mismatch between infarct core and penumbral regions, which is how the mechanical thrombectomy technique, the direct aspiration thrombectomy as first pass. Mechanical thrombectomy is recommended, and the messy device is not recommended. We need a refusion to a modified thrombolysis in cerebral infarction grade 2B to 3. And there are also other AVTS. Which is the benefits how is the benefits in functional outcome? Endovascular thrombectomy for ischemic stroke 0 to 24 hours resulted in better functional outcome than standard medical therapy. For 0 to 6 hours, the 90 days in treatment group functionally independent MRS score 0 to 2 about 46%, and in 6 to 24 hours about 49 and 44%. The safety outcome of the mechanical thrombectomy did not increase the rate of symptomatic intracranial hemorrhage and not decrease the rate, 90-day mortality. About 5% for the symptomatic intracranial hemorrhage, and the 90-day mortality about 15%, and 15%. And the technique success rate about 76 to 84%. This is one case we do. 52 years old male, sudden onset of right limb weakness and emphasis for 6 hours. Past medical history is healthy. The physical examination says the NIS score is 16, with somnolence, consciousness, and motor aphasia, left guide of both eyes, and the right muscle strength is weakness. The diagnosis is acute ischemic stroke, ALS, occlusion of the left middle cerebral artery. This is the CT scan. The aspect score is very good, only with 9. And the CT, and this here is the CTP and the CTA scan. We can find the occlusion of the ME segment of the left MCA, and the infarct volume is very little, only 33 million, and the penumbral volume is very big. So it meets the mechanical thrombectomy criteria. This is the DSA. We also can find the occlusion of the ME segment of the left MCA. It has some compensation. Yeah. Uh, First, we use the swim technology thrombectomy. Uh, this is the aspiration catheter. Here we here we here is the stand catheter, and here is we release the stand. Uh, this is the as aspiration catheter approach the slum bus. Uh, and then we pull back stands to the aspiration catheter. And last, we pull out the aspiration catheter and maintains continuous negative pressure suction. And this is the slum bus. And the final, have full recognition of the left MCA. And the post-operative density has shown no cerebral hemorrhage. 24 hours after the operation, the patient's symptoms have improved significantly. The NIS score only 5, has no gaze of both sides, and the conscious has clear consciousness. The muscle strength recovered grade 4. And we checked the CT and the CT see uh, no cerebral hemorrhage. The intracranial vessel is good. Here is the CT. This is the CT. We find no cerebral hemorrhage, and the localization of intracranial vessel is bad. It's good. And 7 days after the operation, the patient can walk independently, and so can go back to home. And the NIST score is only 3. MRI score is 3. He needed to maintain drugs to prevention of recurrent stroke. This is the neurology department of our hospital in China. That's all. Thanks.